social media platforms, Zoom, JIS Facebook and YouTube channel, the MistyBlue Cancer Care Facebook page and Instagram page. We just want to welcome you all to this teleconference. I suppose you should know that September is Prostate Cancer Awareness Month. And so this evening's conference will focus on prostate cancer. We have a lineup of eminently qualified persons to explore the issues surrounding prostate cancer, analyzing the data, looking at preventative strategies, and exploring the different methods of screening. We also have a very special guest, prostate cancer survivor and advocate, who will share with us his experience and his journey. At the end of the evening, I am sure you will be more knowledgeable about prostate cancer, its treatment, prevention, and all that surrounds prostate cancer. So call your spouse, call your father, call your brother, call your uncles, your cousin, call everybody. Tell them come in and tune in, all right? Welcome again, and thanks for tuning in. So without further ado, at this point, I'd like to invite Ms. Dorothy Satchwell. She's the founder and chair of the MistyBlue Cancer Care Foundation, herself a cancer survivor, to give the opening remarks. Ms. Satchwell.
Thank you very much, Mrs. Holness. Ladies and gentlemen, a pleasant evening to you all. And thank you very much for tuning into our second series in our cancer awareness program, which we started last month, and will be going up until December. And like Mrs. Holness had just said, we will be concentrating this evening's event on prostate cancer. Prostate cancer is one of the leading cancers, both in terms of incidence and mortality globally. And it is also the leading cancer in Jamaica. And this evening, we want to look particularly at prostate cancer in Westmoreland, because Westmoreland, even though it's one of the smaller parishes, for the year 2018, according to the Registrar General Department's data, we had over 1,200 persons who succumbed to cancer in Westmoreland alone for the year 2018. And out of those persons, you have 49 of them who died from prostate cancer. The 49 may seem to be a small number when you just look at it individually, but that's 49 families, 49, it could be 49 fathers, 49 brothers, husband, breadwinner for a family. And when you look at that in the smaller sense, you're looking at an average of 4 men per month throughout the year of 2018 dying from cancer, from prostate cancer. And that is why this month we want to look at it, because this month is celebrated as Prostate Cancer Month. It's also Childhood Cancer Awareness Month, but we are looking particularly at prostate cancer because we want to highlight the plight that is being impacted in the parish by our men and by extension all families, because in most families you find that the men really are the head of the household. MistyBlue Cancer Care Foundation actually started back in 2015 after my cancer experience. And we have been working assiduously with a lot of agencies across the parish, one of which is the Westmoreland Parish Health Department, in trying to reduce the incidence and mortality rate of cancer through education, because we believe that education is one of those mediums that can allow persons to, through the awareness, exercise better lifestyle practices that can minimize the incidence and ultimately mortality of cancer. So this evening we have with us Mrs. June Wheatley Holness, who will be our moderator for the evening. In addition to being a very, very good friend of mine, yes, Mrs. Wheatley is also the Quality Assurance Officer from the University of the West Indies' newest campus, the 5 Island campus, which is located in Antigua and Barbuda. She has nearly 2 decades experience in quality assurance and has written and presented extensively in the area, including 2 book chapters. She's a 2-term secretary of the Caribbean and quality assurance for the University of the West Indies. Her husband is Mr. Andrew Holness, and she said her husband is the #1 Andrew Holness, and our Prime Minister comes second. And she has 2 beautiful daughters, Kayla and Khalifa. So without any further ado, I'm going to hand over to Mrs. Holness, and she will take us through the evening's activities. And thank you very much, Mrs. Holness, and I hand over back to you.
Thank you, Ms. Satchwell. You will realize that the MistyBlue Cancer Care Foundation is a very important organization in Westmoreland and its environs, and by extension, Jamaica. So I'm just going to use this forum to ask you to give it your support, your full support, and ask your friends, colleagues, everybody to support this foundation. Okay. Moving right along, we should have had greetings from the Custos of Westmoreland, but he has sent in his apologies. So we will move on with the program. So at this point, we are getting into the meat of the matter. We now have our first presenter, Dr. Mong Ong, who will break down for us the data on the incidence and mortality rate of prostate cancer in Westmoreland between the years 2004 and 2018. And he will also explore, tell us a little bit about the epidemiology of prostate cancer and preventative strategies. And just to give you a little bit of background about Dr. Ong, he's a medical epidemiologist and the head of the Epidemiology and Research Unit of the Western Regional Health Authority in Montego Bay, Jamaica. He's a naturalized Jamaican, a native of Burma, Myanmar. He earned his Bachelor of Medicine, Bachelor of Surgery degree from the Institute of Medicine in Myanmar, and also a Master of Public Health from the University of the West Indies, Mona. He is a member of both local and international scientific organizations and other professional associations. He teaches epidemiology courses in local universities here in Jamaica, and is also a visiting professor at the University of Alabama in Birmingham, USA. He has authored several scientific papers, abstracts, posters, and presented at local and international conferences. Dr. Ong lives in Montego Bay with his lovely wife and 2 sons. I am sure you will agree that he's well placed to examine the data and interrogate the issues on prostate cancer. So, Dr. Ong, over to you.
Okay, I'm trying to unmute my mic. Thank you so much for your lovely introduction, Madam Chair. I'm going to share my screen. Just give me 1 second. Can you see the screen?
Yes, I'm seeing your presentation screen, Dr. Ong.
Okay. Thank you so much for your lovely introduction, Madam Chair. And I'm going to briefly describe the prostate cancer incidence and mortality data for Jamaica and also Westmoreland. And I would like to thank Misty Cancer Care Foundation for giving me this opportunity. You know, I don't know how many of you know American Chinese comedian. His name is Joe Wall. And one of the shows, he said that I used to be the world's youngest baby. He is referring to the fact that when he was born, he was the youngest baby in the world, and which is not happening anymore. Now he's getting older day by day. So are we. We are getting older day by day. So when we are getting old, there are different things are happening, good things and also bad things. And for good things, we have as we get older, we have better social skills and we have more in terms of empathy. We have grandchildren. I don't have any as yet, but I wish I'm going to get some one day. So you are getting grandchildren and you're getting happy about it. And also you have more times for your loved ones. So you spend more times at home with your loved ones. So that's a good things. On the other side, we also have bad things because of we are getting old. One of the things is that we are getting thinny hair. For me, none. My hairs are gone. And that's one of the bad things that happen with when you're getting old. And your body started to slow down. You're not used to be like when you are young. That's one of the bad things that happen to when you're getting old as well. And your joints, your knee, other joints, and the whole body hurts. Arthritis kicks in and all of these. So in addition to all of that, based on the physiological status and physical status of your aging follows, you have to spend more times in the doctor's office, and sometimes you find yourself in the hospitals being admitted to the ward due to the fact that you have getting old age diseases, and in Jamaica, hypertension, diabetes, more prevalent diseases. And one of the things that comes with the aging is cancer. It is not that cancer happens only in old age, but old age, when you're getting old, chances are that you're going to get cancer, one of those cancers. So population status and aging, I'm trying to link those two things together. So when you look at the population structure of Jamaica, this is a population structure for Jamaica, we are looking at over 80 years. So when you look at 1970, you see our population structure is like younger populations built the Jamaican population. So you can see more persons in the younger age group. So when you reach to 2020, now we are at 2020, you started to see the pyramid, the belly of the pyramid started to get wider, and you are started to see less persons in the bottom of the pyramid. And when you reach to, it is anticipated that when you reach to 2050, you are going to see more persons in the older age group that form the population structure of Jamaica. So that's going to be an implication for individual level, and as a country level, also healthcare services level. You are going to be having more persons coming in with chronic non-communicable diseases, and cancer is going to be one of them. One of the reasons why we are seeing less persons in the younger age group is that we are started to see the slowdown in the fertility rate. In fact, after 2000, we started to see our fertility rate in Jamaica has declined significantly. So that's one of the reasons why we are seeing less persons in the younger age group, which form the population. So what is cancer? Briefly, cancer, also known as malignancy and also known as neoplasm, is a large group of diseases that can start in almost any organ or tissue of the body when abnormal cells grow uncontrollably, go beyond their usual boundaries to invade adjoining parts of the body and or spread to the other organs. There are a little over 200 different types of cancer that can occur in human body. So my outline of the presentation is going to be on, I'm going to show briefly on global statistics on cancer, and coming down to Caribbean and coming to Jamaica, and now we narrow it down to Westmoreland. According to Global Cancer Statistics 2018, that was published in 2018, Globacon, that's a paper which estimates of incidence and mortality worldwide for 36 cancers in 185 countries. That states in both sexes, lung cancer is one of the it's a major leading cause of cancers in both sexes. But for male population, it's lung cancer followed by prostate cancer globally. And female, breast cancer is a leading cancer in female population globally. I just want to introduce this index we call Human Development Index. This is the index they use to score a country whether or not how do they do in terms of healthcare services, in terms of education, in terms of income. And it is defined as a summary measure of average achievement in key dimensions of human development: a long and healthy life, is one of them. Being knowledgeable and have a decent standard of living. So those are the indicators that they used to measure and call Human Development Index. So if you want to score a country, and if the country scores higher HDI, when that country lifespan is, persons living longer in that country, and they are well educated, and their gross national income per capita is also higher. So that means that if you are seeing more high in HDIs in that country is doing very well in terms of all aspects of the humanity. For 5 leading causes of death in globally, this is causes of death worldwide and using the HDI, and this is the statistics on 26. So using HDI and identifying the leading causes of death globally, and you can see one is the first leading cause of death is cardiovascular disease. That's happened to whether or not you're low or medium or high. That is across globally is cardiovascular diseases, and followed by the second rank globally is malignant neoplasm, that's cancer. But when you look at low HDI countries, cancer is not the second leading cause of death. But when you look at medium and high HDI countries, the cancer is second leading cause of death among those in those countries. So where Jamaica stands? Jamaica stands is classified as high HDI, and thus you can see in Jamaica, neoplasm or cancer is second leading cause of death in the country. When we look at the Caribbean, that's the data for 2018, the 5 most frequent cancer, excluding non-melanoma cancer, skin cancer, excluding that cancer, the top 5 most frequent cancers in the Caribbean. Prostate is the first, followed by lung cancer, colorectal cancer, stomach cancer, and larynx, cancer of the larynx. And also, it is to note that if you're living in Caribbean, one of the countries in the Caribbean, risk of you dying from cancer, especially in men, before the age of 75 years is 11.7%. So it's a 12% the risk of dying from cancer. For Jamaica, the burden of the cancer, again, it's a statistic 2018 data. Again, top 5 most frequent cancers in Jamaica is prostate. Again, prostate is the leading cause of cancer, followed by lungs, colorectal, stomach, non-Hodgkin lymphoma. So those are the cancer, but prostate is the leading cause of cancer. And also in Jamaica, if you, as a man, Jamaican man, risk of dying from cancer before the age of 75 is 13%. So that is something important to note. And again, for WHO, World Health Organization published data, and you can see most common cancer cases in 2018 is prostate is leading in terms of incidence and also in terms of mortality compared to the remaining cancers. So breast cancer is second leading cause of cancer in Jamaica, but in terms of incidence and mortality rate, prostate cancer is leading all the way. Now, local statistics, looking at the cancer trend in Jamaica 30 years from 1958 to 1987, that's 30 years. And this study also saw prostate cancer is the most prevalent cancer in Jamaica among Jamaican men. And we also looked at from 1988 to 1992. Once again, prostate cancer is the leading cancer in male population. From 1993 to 1997, again, prostate cancer is found to be a leading cancer among male population in Jamaica. And again, in 1999, leading cancer mortality sites for males were prostate. So you can see from now, you will realize by now that from 1958 to 1999, we're talking about over 40 years. Prostate cancer has been a consistent and leading cancer. Now, looking at a little bit localized data, which is Western Regional Authority, where I work. We have 4 parishes, Hanover, St. James, Trelawney, and Westmoreland. And you can see the data from 2008 to 2011, male population. prostate cancer, we are seeing increased number of prostate cancer. This is the percentage of the cancer seen among other cancer. Prostate cancer is leading, and they are increasing year by year. And most persons who are diagnosed, like I said, diagnosed. So it is not the screening data, it is diagnosed. It is very sad to see that most persons are diagnosed with symptoms, which means that they already sick with the prostate cancer, you know, and sometimes it is too late for us to do intervention. And trend of prostate cancer in Westmoreland from 2004 to 2018. If you are familiar with Westmoreland located in the western part of the island with the approximately population of 150,000 population, and sugarcane cultivation is well known in Westmoreland. In addition, they have Negril, city of Negril. Negril is the famous globally for tourism, you know, beauty of sea and sun. And so most persons, the tourism is one of the economic activities happening in Westmoreland, and eastern part of the parish. They also do the farming as one of the major economic activities in Westmoreland. In terms of population structure, from 2001 to 2017, we have started to see increased number of population in Westmoreland, and more significantly, in Westmoreland, 14% of the total populations are more 40 years and over. So that's a high risk group that we are looking at for prostate cancer. 14%. And male to female ratio in Westmoreland is 1:1. In terms of health service provision, we have primary care and we have secondary care. Primary care sites, we have different health centers located strategically throughout the parish, and by the health districts, and different types of health centers from type 1 to type 4, and different type of services are given to the population in the primary care sites. For the secondary care sites, we have type B hospitals with 200 beds. They offer emergency services, internal medicine, general surgery, OGD, and pediatrics. And they also do the prostate diagnosis and treatment there. In addition to government facility, we have a private facility called Rail Medical Center, and we have a number of private doctors' offices in Westmoreland. So the service, the health service provision is given to the population throughout both private and public sectors mixed. If you recall HDI, Human Development Index, that was looked at in 2017 within the country, and you can see Westmoreland has a relatively low HDI compared to the parishes in the east. Well, in fact, St. James, you know, western parishes has a low HDI. And I have questions about that, but nevertheless, yes, we have low HDI in Westmoreland, and we looked at the different types of cancers in Westmoreland, starting with prostate, cervical cancer, breast cancer, trachea, lungs cancer, and colorectal cancer, and stomach cancer. Of those cancers, you can see the prostate cancer has been the highest in terms of deaths. This data is from Registrar General Department. So when the person died, and causes of death are being registered in the registered RGD, and this is the data taken from RGD. So we have in Westmoreland, most cases persons dying, most persons dying from prostate cancer, and followed by malignant lung cancers, and followed by breast cancer. Okay, so those are the top 3 cancers in Westmoreland. In terms of leading causes of cancers in Jamaica, in male population, we are looking at all 14 parishes, and 23% of deaths in male population in Westmoreland are due to cancers. Of those cancers, prostate is the major leading cause of deaths among men in Westmoreland. Again, compared to other parishes, this is just the absolute numbers from Registrar General Department. Compared to other parishes, maybe are different in terms of population size, but Westmoreland has the relatively low in terms of number of deaths due to cancer. That's maybe due to the fact that population size may be different from other parishes. But looking at the trend of prostate cancer in the parish of Westmoreland, the trend, there's no significant peak that, if you will. However, when you look at from 2004, and it seems to me that the cancer deaths among male population in Westmoreland has significantly increased, especially in 2017. So, in general sense, the recommendation, the conclusion can be made based on this graph is that we are seeing more persons are dying from prostate cancer among male population in Westmoreland. So, in summary, in Jamaica with the high HDI, cancer is the second leading cause of deaths, and prostate is the leading cause of cancer deaths among male population in general. For Westmoreland in particular, Westmoreland has a relatively low HDI, and 5 out of 10 are 30 years and older. In fact, 14% of the population are 40 years and older. It is not the highest in the country in terms of cancer deaths compared to other parishes. 23% of the deaths among male populations are due to cancers, and top cancer is, again, prostate is the leading cause of cancer. And there is no specific trend observed in the prostate cancer deaths in Westmoreland in male population, but it seems as if it's to be increasing in terms of deaths among male population due to prostate cancer. Okay, so I stop here, and thank you so much for listening. I don't know if you want to ask questions or before I move to another presentation. Over.
Okay, thank you, Dr. Ong. Okay, you will move into the other presentation.
I do have a question.
Oh, okay. Yes, Ruben?
Good evening, all. Doc, you outline a 40-year stats, but I didn't hear you continue to say there are studies available showing what has caused prostate cancer to be so prominent. Can you address that issue?
Thank you for the question, sir. I think it's going to be on my second presentation. It's going to address why. There are some studies that I'm going to be showing in my second presentation. Epidemiology of prostate cancer. Hopefully, if you be patient and wait for a little bit, I hope that my second presentation will address that.
Okay, thank you.
All right, thank you. What I'm gonna ask you to do is to just place your questions in the chat. After all the presentations, then we'll have a question and answer session. So we ask Dr. Ong to move on to his second presentation.
Okay, just give me 1 second. Okay, you see technology, so I'm trying to bring up my second presentation. Okay, thank you so much again. This is my second presentation. I'm going to put it on the slide show. Can you see the slide, please? Can you all see the slide?
Yes, we can. Yes, we can.
Yes.
Okay, thank you. All right, so this is going to be my second presentation on the cancer, and let's see I can address some of the concerns that you may have. All right, so I'm going to be talking a little bit about epidemiology, descriptive. It's somehow, I have addressed the descriptive in a previous presentations. I'm not going to go to that, but we're going to look at the risk factors, why we are having more persons or more men, in Jamaican men in particular, having high risk of getting prostate cancer compared to others. We're going to show some evidence to support that. And I'm going to briefly outline what Ministry of Health and Wellness in Jamaica is doing about the prostate cancer or cancer in general. And I'm going to end with my summary of the presentation. So what is epidemiology? Being an epidemiologist, I'm going to start with the definition of the epidemiology. There are so many definitions, and this is something I like. It is defined as the study of the distribution and determinants of health-related status in specified populations and the application of this study to control of health problems. So that is the basic definition of the epidemiology. So one, we are going to be looking at the epidemiology of cancer, in this case, prostate cancer. We can define in such that the study of the distribution and determinants of prostate cancer in Jamaican men and the application of this study to control the prostate cancer in that population. I know just to refresh our memory, we know where prostate is, but prostate gland is a firm, partly muscular chestnut or sized gland in men. Prostate sits at the base of the bladder with urethra tunneling through its center. Its function is to produce majority of the seminal fluid that carries sperms forward with ejaculation. At the time you were born, prostate is about the size of a pea, and prostate experiences 2 growth spurts at the time of puberty and at around age 50. So this is where the prostate is graphically. So there are 3 common prostate problems, and one is prostatitis or inflammation of the prostate. So this is the inflammation of the prostate gland that may result from bacteria infection. The second most common problem is benign prostatic hypertrophy, and also known as BPH. This is the enlargement of the prostate gland. It's not the cancer. It does not change to cancer, but that can lead to retention of urine. That's the commonest problem when it comes to that particular genitourinary system in men, retention of urine. And the third one, which is our interest, is prostate cancer or cancer of prostate. That's a cancer that forms in tissue of the prostate, and there are different types. Adenocarcinoma, which is the commonest type, 95%, small cell carcinoma, squamous cell carcinoma. So there are 3 different types, and there are others. According to the Jamaican Cancer Society, it is estimated that 1 in 10 men in Jamaica in our population will be diagnosed with prostate cancer, one of the leading cancers in Jamaica. Do you know how some Jamaican call prostate? Something that I can learn, being a naturalized Jamaican, they call prostrate. So when you ask the little old man about what happened, Doc, I have a prostrate problem. So, at the beginning, I have difficulty in getting that. What is that? And finally, I found out that they call prostrate. Not everybody does. Some call prostrate, and that they mean prostate. And also, when I used to work in the hospitals, and I used to do the catheterization for the persons with urinary retention. That's one of the commonest problems in the urology clinic. And one day, one of my consultants called me and asked me, "Do you know how Jamaican call retention of urine?" And I said, "No, I did not know that." And that's why I learned the phrase called stoppage of water. Stoppage of water. Well, it makes sense. Water stopped. So stoppage of water. And that's something that, even though being a doctor, you may know most of the things that you don't know. If you don't know the local culture, you're going to be in trouble. All right, so we're going to talk about risk factors. Generally for the cancers, that's for not necessarily for prostate cancer, but generally for cancer. In Jamaican population, we have obesity and physical activity. These are what we call modifiable risk factors, something you can do about it, even though you may be exposed to it. If you can change the risk factors and you can avoid any diseases that may be caused by these risk factors. And starting with obesity and physical activities. So in Jamaica, there is a study called Jamaican Health and Lifestyle Survey. There are 3 types, three surveys so far were done, and the one was published in 2016 and 2017. Jamaican population, 1 in 2 Jamaicans, 54% were classified as overweight, pre-obese or obese. That's significant. And also when it comes to physical activities, we are not doing very well in terms of physical activities. 82% of Jamaicans were engaged in just low physical activity, just moving from one place to another, just going to the offices and so on. 16%, only 60% moderate, and only 2% are in high physical activity. So they are going to the gym, they are doing physical exercise for 30 minutes and so on. So those two risk factors we found in the Jamaican population. And when it comes to Westmoreland, and this is something that Mr. Miller would like to make a note of it, in male population compared to the rest of the parishes, Westmoreland ran second in terms of obesity among male population. That's significant. In terms of dietary practices, this is one of the modifiable risk factors causing cancer. The same study found that 28% drank at the sugar sweetened beverages once or more daily. That's significantly, but it's a significant things that we need to correct. That 1 in every 10 consumers excess salt. That's also leading to the non-chronic communicable diseases, including diabetes and hypertension, and one of them is cancer. In terms of tobacco and harmful use of alcohol, the same study found that 41% of 50-year and older use alcohol was half of it, that population. And 50% of 50-year older use tobacco products. That's current. So we have persons who smoke 50 years and older, and that can lead to at some point cancer in the. So coming back to Westmoreland now, so we looked at the study done by study from the rapid assessment and response done by National Council of Drug Abuse in 2010. The prevalence of drug abuse and abuse in Westmoreland is that 34% have ever used cigarettes, 34%, and 37% have ever used ganja, and 91% have ever used alcohol. It seems that compared to other parishes, Westmoreland has a lot of persons who drink alcohol. And some of the reasons alcohol is the most abused drug in the Westmoreland is that 76% of the persons consume alcohol make them feel good, relax. So we did not find a significant link between alcohol and prostate cancer. There are some studies also found that there's some sort of weak link between cancer, prostate cancer, and alcohol. For prostate cancer, the risk factors are that, man, if you're a fit male, you cannot avoid that. So male being a man is the risk factor for prostate cancer. As we get older, 1 in 7, almost 8,000 men younger than 40 has prostate cancer. As we get older, 1 in 8 men age 70 years and older will get prostate cancer. So age is one of the significant factors that we can. And compared to when you look at the study, the same study that I mentioned previously from 1978 to 2007, the major diagnosed prostate cancer in age groups are 60 year and older. So older age groups, what you are the one that we commonly diagnose with prostate cancer. Western region, Corner Regional Hospital is one of the type persons with 60 years and older, 20%. Those are diagnosed with prostate cancer. Again, these persons were diagnosed when they are having sinus symptoms. Rural versus urban. We did 2 studies in the Western. And from the studies, what we found is most persons that we identified during the studies, most patients are coming from rural area. So if you live in a rural area, if you live in Westmoreland, for instance, are you having more risk of having prostate cancer? Something that we need to find out. For race, it is common in African American men and Caribbean men as well, and less common in Asian American and Hispanic American. So it's race is something to do with it being susceptible to having prostate cancer. So international pattern is show. I'm going to point out the last one, the bullet number 3. It's very interesting. Migration studies. It shows that men of Asian heritage living in the United States are at lower risk than white Americans, but greater risk than men of similar countries living in Asia. So for instance, myself, I'm an Asian Jamaican. I may be more high risk of having prostate cancer than my brother and sister back home in Myanmar. You know, so it's something to do with the activities that I do here, or maybe whatever it is that I'm being exposed to in that part of the globe, put me in the high risk of having prostate cancer. And compared to United Kingdom, United States, and Caribbean trend, and when you look at Jamaica, even though Jamaican men are considered as one of the high risks of having prostate cancer, but when you compare with other countries, United States African American Black population, and United States African American population, and United Kingdom, we are the lowest. I mean, not the lowest per se. I mean, we are higher than Caribbean, but compared to others, we are still lower than those countries. Another risk factor is family history, especially first-degree relative, meaning it's a person, parent, sibling, or child. So if you have a family history of first-degree relatives having prostate cancer, you are likely to have prostate cancer. Your chances of prostate cancer are 5 to 10%. I'm going to move that, family history, and the diet is another risk factors. Diet. There are many studies about diet, and when we look at fruit and vegetables, tomatoes, it has a decreased risk. Broccoli, increased risk. Protein, if you soy has a decreased risk. I'm not going into detail for that, but when we look at the other factors, one study found that there's no significant association between smoking and alcohol use has been observed. So smoking and alcohol use may not anything to do with prostate cancer, but all cancers, smoking and alcohol use are one of the modifier factors. And there are other studies, they have found that alcohol may be linked to the causes of prostate cancer. For diet, local study, there is a study, very interesting study, prostate cancer and ackee, you know, one of the our national fruit. There is an association between dietary fatty acids, which is inside the ackee, and prostate cancer. That was published in, I believe, sometimes in 2012 or 2014. But that's the only study that we have identified. And there's no studies can support or deny the fact that that is the case. So only one study that we have found, and there's no one who is doing the study to repeat that findings to support that. And another study is the vegetables, the pattern, meat patterns, and fast food pattern. They are associated with the prostate cancer risk. And the data suggested that a carbohydrate dietary pattern, high in refined carbohydrates, may be the risk factor for prostate cancer in Jamaican men. So, you know, those refined carbohydrates, those are very common in the western part of the globe. So maybe that's something to do with the cancer incidence and prevalence. And we also know about key facts about men's health. Prostate cancer affects only men. Men tend to smoke more than women. Men tend to drink more than women. Men tend to have more sexual partners than women. And men don't seek medical help as often as women. So we have macho mentality is existing in Jamaica. Some men define themselves by their work, so which can add to the, you know, this kind of ego, and they also think that they are more stressed than other person. That's why they end up with cancer. Now, we have some studies that I'm going to briefly explain or describe. We have two studies. The studies done by Morrison et al. And 28.2 Jamaican men, 40 years and older, have ever done digital rectal examination. So the uptake of the digital rectal examination is very low. And if you live in a rural area, you are afraid of doing, or you are not going to do digital rectal examination. only 5% of Jamaican men 40 years and older were sent by health practitioners or PSA, by prostate-specific antigen, one of the diagnostic tools. And that's also very low. Another study found that older men tend to screen for prostate cancer in Jamaica, older men, but compliance with the regular maintenance visits. So they tend to come for the screening, but they stop coming after the first visit or second visits, and they stop. They are not complying with the follow-up visit. So when they come back to your health facility, it's already late. Another one, which we did was cross-sectional study, and where we found is the knowledge, attitude, and practices. Most persons who recruited in our study did not know what and where the prostate is. And only 35% were previously screened, very low, and you are less likely to be screened. What we found is when you live in a rural area, if you've never been advised by the doctor, and don't visit healthcare practitioner or providers annually. So we recommend that men 50 years and over needs to be educated of regular visits and prostate screening. Another study, case control study, in that most men know the screening of the prostate, but they did not act on it. And more cancer patients were diagnosed when symptoms appear, which is very, very sad. And age and family history and all use of major findings in our study person with prostate cancer. So we need to do a target intervention for those persons who we have identified in the study. We need to identify them, even though you need to come to the doctor for screening. Why you did not act on it? What are the disconnects? For the Caribbean study, for high risk and low risk mortality, high risk and high mortality population, especially Jamaica, we have identified that minimum survival benefits to men over the age of 60 years. When you screen for persons over 60 years and older, it's a minimum survival rate. But it appears that when you screen for persons younger than 60 years old, the chances of living longer is more. So the message is that we need to get more persons 60 years and less to screen for their prostate. So what are the preventative strategy? You need to check yourself. What's your risk? If you're a man, okay, if you're a man, you're high risk of getting prostate cancer. If you're 40 and older, are you obese? Do you smoke, drink? If you have any family member with prostate cancer, if you check one of those, and you may be at risk of developing prostate cancer. In that case, it's still early for you to go and check with your doctors about prostate cancer. So in terms of strategy, what we use is understanding the natural history of the disease. So at some point, we are exposed to all the modifiable risk factors, alcohol, smoking, obesity, exercise, and so on. So we need to change our lifestyles, avoid and modifying our modified and non-modified. We need to modify and we need to practice healthy lifestyle. So you do exercise, you reduce your weight, you take your full personal responsibilities of not being exposed to those risk factors. But at some stage, there is a pathological changes taking place inside your body, and prostate started to get bigger and so on. But you have not reached to the stage where signs and symptoms appear. At the stage, we need to do screening to catch those changes in the early stage. So we implement screening. The screening will going to take place there, and we can catch the disease at the early stage, and we can do the intervention. And these are some of the primary prevention that we're talking about: the Jamaica Move, exercise, personal responsibilities, and screening. I know Dr. is going to talk about screening later, so I'm not going into that. We have two different types: digital rectal examination and prostate-specific antigen. Those are and there are others, but those are the two intervention that we provide as a screening tool in our facilities. Our approach is that if you want to talk to the doctor, please approach the persons at the primary care level, which is in the health center level. When you go to the major hospitals, you may not be able to talk to the doctors, and doctors, healthcare providers may not be able to talk to you because of the high traffic in that area. But when you come to the health centers, that's why you can, communicate with your doctors, and you can do the risk assessment there And from there, if we have identified something, not necessarily only prostate, other diseases, those will be sent to the what we call referral system, where you will be sent to the proper channel with the appropriate centers, where maybe hospitals, maybe to the diagnostic center, or maybe to any specialist care area. Okay. Now, those services are available in, like I said, primary care and secondary care. And I would like to emphasize that you use primary care services where you can get screening for prostate. We offer digital rectal examination, and PSA, prostate-specific antigens, are offered there. All right, so in summary, although it's still not the highest in the world, prostate cancer incidence in Jamaica is still high compared to the rest of the Caribbean. Incidence continue to increase in Jamaica. Jamaican men have the many known risk factors, modifiable as well as unmodifiable risk factors. And Jamaican men are well known for their low health seeking behavior. And despite the knowledge, screening rate is still low for Jamaican men. And 70% of the patients were diagnosed with the symptoms. This is what's happening in the reality. But evidence suggests to us that if you detect early cancer, it can prolong the survival rate. These are my references. And thank you so much for listening. I may have taken sometimes my time limit. Thank you so much for listening. Over.
Okay, thank you so very much, Dr. Ong. Lots of food for thought, lots of food for action, very rich information there. We're hoping that you're writing down your questions, you're putting them in the chat, so that at the end we can interrogate all the information that you've received so far. We are going to move on now to our next presenter. Our next presenter is a prostate cancer survivor and advocate, and he has graciously agreed to share with us his lived experience. For this evening, we'll call him our hero. He's Mr. Pete Manboard. And just a little bit of background on Mr. Manboard. He is the third child for his parents, and he is from the parish of Westmoreland. He holds a diploma from the George Brown College of Applied Arts and Technology in Toronto, Canada. He has held several executive positions in the hotel and tourism industry, including assistant manager of the Sandals Resort. In 2012, he ventured into operating Jamaica's first and only mobile museum. A year after its birth, the Manby Special Museum and Culture Bus was awarded first place in the NCB in the innovation category by the NCB Nation Builders Initiative. He is also the vice president of the Westmoreland Lay Magistrates Association. Mr. Manboard is a musician, and he has shared his skills at schools and churches and widely across Westmoreland and beyond. We thank you so much, Mr. Manboard, for agreeing to share your journey with us. Over to you, sir.
Okay, sorry, my mic was muted. Are you hearing me clearly now?
Yes, I am. Yes, I am.
Okay, thank you for the opportunity to share, with the wider public in terms of my journey, having been labeled as a survivor of prostate cancer. I was diagnosed in 2014, I believe it was. Well, what happened prior to that? During my 40s, I did my examination, I think about 3 times, which of course is one of the mistakes that most of us as men do, not doing it annually. And then I didn't do it for a number of years. And I remember I was doing Oh, sorry. Okay, I wasn't showing my video. Are you hearing me, Miss June?
Yes, I'm hearing you. I'm seeing you as
Okay,
well. Great.
right. I was not showing my video. So I remember doing I was helping out Father Perrin at a health fair at his church in Petersfield one evening, providing some sound for him. And I remember distinctly the doctor, I don't remember his name, from Savlamar Hospital. They were talking about prostate cancer. And then it dawned on me that I did not do my examinations in about 3 to 4 years. So I purposed in my mind to go and do it. However, one morning shortly after that, I had a dizzy spell and rushed to the hospital. And then after the examination, doctor diagnosed it was my pressure. I'm hypertensive. But then after that, I remember Dr. Chisholm asked me, when last you do all your your blood works? And I said, well, it have been a couple of years I didn't do any. So he recommended for me to go and do the blood works. Upon doing the blood works, we recognized that the PSA level was high, and that's where the concern came in. So he recommended for me to go and speak to Professor Lawson Douglas, who comes to Royal Hospital. I don't know if he still does, but that's I went to see him and did the a matter of fact, when Dr. Chisholm did the DRE, he didn't feel anything abnormal. And upon the examination by Professor Lawson Douglas also, he did not feel anything abnormal. However, he suggested that I might be suffering from prostatitis. So he put me, I was placed on some medication for about 2 months. The PSA level came down. Or let me just tell you, the level of my PSA at that time, normal PSA should not go above 4. My PSA was in the 30s, which was extremely high. When I got the medication, for about 2 months, it came down to the mid 20s, which is still considered extremely high. And it is then that he decided I needed to do a biopsy. So when I did the biopsy, it was conclusive. I was diagnosed with cancer. Right. It was something immediately hard to accept. I was at that time 51-year old. I mean, in the prime of my life. Why is this happening to me now? Because when I look back on the history as a doctor present before, that one of the things is that or one of the risk factors is family history. I never had anybody immediately, not my father, not my grandfather, not my great grandfather, no uncles with prostate problem. So it had me wondering, why this at this moment. Um, the doctor tried to how should I put it, comfort me in saying that um don't worry too much about it, right? But just be prepared for to most likely do a surgery. So as I said, after the biopsy came back, it was conclusive, and I sought other opinion. Apart from him, I spoke to other friends, other doctors. I remember clearly speaking to Dr. Nepal one day at a function, and he said to me, Pete, don't hesitate. Just chop that thing out immediately, rather than the option of treating it. And I begin to think more positively about it, and rather than worrying, which a lot of persons do when they hear, because some people don't even want to hear the full name cancer. They just want to hear the big C, and people start worrying. So I embrace it, and my faith in my creator, I have to put that forward, gave me the strength to accept and to readily deal with the outcome of this diagnose. So I did all that was necessary. I spoke to a couple other doctors, and then I was referred to another doctor in Montego Bay, a urologist, Dr. Roy McGregor. I went, brought all the documents to him, showed him, and he also concluded that as soon as possible, you should get this do the surgery. So I opted to go with the surgery that he showed to me, which was laparoscopic, which in truth and in fact gives you a quicker turnaround in terms of recovery. And I was really afraid of a knife cut, so to speak, all the way down the tummy. So I went for that option. So I did my surgery in 2015, having been diagnosed from 2014. The reason of the delay, it was scheduled for December of 2014. And what happened, I remember, if you remember, we had the chickpea virus outbreak at the time, and my doctor, unfortunately, got the chickpea. He couldn't perform it. And then it was rescheduled for April of the following year, 2015, or March or April. And then he got a second bout, and that affected his dexterity. So I actually did the surgery in June of 2015, right? So that's a little over, that's 2015, yeah, a little over 5 years. Yeah, a little over 5 years now. Um, Treatment after that, I didn't do anything after the surgery. But I did a follow up in terms of my PSA examination in the first instant every every 3 months, right? So every 3 months I did it, and it was at the level at what it's supposed to be. It was at 0 point something. I don't remember the exact thing. Right. I was cautioned though if I see any upward movement to you know let the doctor know. Well, he would have gotten the result, and we would decide what to do after that. So one of the things about prostate cancer and about the whole examination process is that most Jamaican men, it's really a taboo thing that most Jamaican men are afraid to do the examination because they don't want that doctor's finger to be inserted in the anus. It's a taboo thing, and I really want to emphasize on that because the Jamaican and I will say it, the Jamaican thing about losing a man's virginity through his anus from a doctor's finger. And then the other thing is that a lot of Jamaican men tend to be afraid of losing their erectile function. And I probably think that this is the main thing. So some men shy away from doing the examination because they don't want to be told that they have prostate cancer, have to do the surgery, and um, you know, as a result, may lose their erectile function. Because the macho thing about most men, Jamaican men, is that as long as they can they have their erection, they have this what should I say, this power of a woman, and they can service whatever they want to do. But that is a concern, and that is one of the things that a lot of men are afraid of. As I said before, I embrace, by the help of the Almighty, I prayed about it. I embrace the fact that hey, it is not something that you brought onto yourself, but it's just a condition that have happened for whatever reason. In fact, when I spoke to Dr. Lawson Douglas about it and asked, what are the causes? And his answer to me was, "Mr. Mangold, if I knew the exact cause for prostate cancer, then I would be nominated for the Nobel Prize." So in other words, there was no conclusive thing as to what particular um you know what really caused the prostate cancer. So I embraced it and I did what I had to do. I one of the help for me was when I joined the MistyBlue Cancer Care Foundation. And as you heard, Dorothy spoke before. She's also a cancer survivor. We are from the same era, so we share a lot, and that enabled me with speaking to other persons and relating my experience and their experience. It was indeed does have an effect on you mentally, right? Because no one wants to know that they are carrying the cancer virus or the disease, and eventually it might be the cause of their life, right? So it was concerning, and sometimes like Job, I quarrel with God and ask him why me, and as I said, but I prayed about it. I shared it. I'm one of those persons who don't who's not afraid to speak publicly. And through the foundation, I've gotten the opportunity to speak at some forums at churches or at the health fairs. I've also done it on my own at some other forum, because for me, one of the things I accept out of it is that maybe God have prepared me as a strong person to become this advocate that I am, because there are a lot of persons who don't want to talk about their illnesses, for the primary reason that they think that the stigma is going to be attached to them. People are going to look down on them. People are going to say all sort of things about them. For me, it was nothing like that. I really embrace it, and I cherish the opportunity to speak about this, as much as I can. Um, in terms of signs, I really didn't see any signs of this coming on. There's one thing that I was experiencing sometimes, which I did not know that it was until when I was in that forum at the health fair. Sometimes I'll be on the road for the whole day. Didn't feel like I want to urinate, but as soon as I get home or stop, um, there was a sudden rush, like you almost couldn't hold hold the urine. And I've learned since then that that is one of the signs, right? But I implore all men, whether here in Jamaica or otherwise, that start doing the annual examination, if possible every year, as soon as you get to the age of 40, because knowing if you are carrying the symptoms, knowing if their disease is there, knowing it at an early stage is better off than when it gets to the stage that you might have to do a surgery. Some persons, don't have to do a surgery, but really do a treatment. And I'm thankful that I caught it at this stage, because I was diagnosed 6 years ago, and I'm still here. Um, Presently, I am doing radiotherapy treatment, because the PSA level have been over the past, I think since late last year, 2019, about November, December, I realized that the PSA level was inching up a bit. So in dialogue with my doctor, my urologist, he recommended that I should consider doing the doing the treatment. So he recommended I speak to the oncologist at the Cornell Regional Hospital, Dr. Sharma, and out of that discussion, it was recommended. So I'm presently doing that. More of a preventative measure. It did not go. The high point when I tested it last was, which is about two 2 months ago. It was at 3 point, I think 3.7 something, right? But as I said, I'm doing the radiotherapy treatment currently. It's a 8 weeks program. This weekend will make my third week. But I just want to implore men to do the test when it's necessary to be done, and for whatever reason, if you might get to the stage that I got in terms of having to do a surgery, be positive, because one of the factors, and it was pointed out in the doctor's presentation, is the whole stress level. I thought I didn't think that I had a severe dietary problem, because I have cut out certain things in terms of meat fiber a long time ago. Not necessarily cut out all of it, but eat less of it. Consume a lot of vegetables. Um, I've cut out sugar for some time ago. Primarily been using honey for years. So I thought, I could never catch it, or couldn't get it from any of that reason or those risk factors. I still don't know, but as I said, I was diagnosed. I embraced it. I did the surgery, and I am here, alive and thankful. Unfortunately, I've lost two friends since my surgery, and primarily because they were very hesitant in doing the necessary. One of my friend, I actually said to him, "Let me go and do." He did the test. The PSA was high, um, and he was the doctor recommended him to do a biopsy, and he was actually afraid to do it. I said to him, let me go with you. He was actually waiting on his wife to come from the United States, and when she came and they did the biopsy, and when he eventually know the state of it, within I think it's within 2 3 months he died. So I implore men to embrace. There's a old Jamaican saying, say, sickness don't make the only dog. Start to say, but we are sometimes so afraid of being told that we are carrying certain disease, and it's in a matter of fact one of the things that Professor Lawson Douglas said to me, which at first when he said it, I was taken aback. He said, "Man, but look at it this way. We all have to die of something. So just prepare your mind for anything to happen. But be positive in whatever you do. Be positive in your thinking. And if you're positive in your thinking, you will be successful in this thing." Yes, June.
Thank you so very much, Mr. Manbo. That was truly inspiring. Thank you so much for your frankness, for your willingness to speak, and for just sharing with us. We wish you well. We wish you long life, and I'm sure you will live to see many, many more years. And you have the right attitude, and I'm sure you'll fight this. So
I,
thank you so
I
much.
am a very positive person, and as I said before, I don't allow it to get to me or to put me down. There are times when you are at your low point. It's just natural. But I'm a positive person. That I try to surround myself with positive friends too, and who can talk boldly about these things and accept what have happened in your life.
Great, great. Really, really appreciate you sharing with us. So thanks again.
Well, I'll be here for any question afterwards.
Yes, I am sure there will be a lot of questions. We will get back to those questions at the end. But we have to move on. We have a bit of time constraints, so we're gonna move into the next presentation, and then we come back where you can answer the questions that will be posed. So thanks
Sure,
again.
sure. I'll be here.
Great, great. All right. Okay. Right. So moving right along, we will now have our next presentation. We'll hear from Dr. Gareth Reed about the different methods of prostate screening, and he will answer the question, how does Jamaica measure? A little bit of information about Dr. Reed. He is a consultant urologist at the University Hospital of the West Indies and an associate lecturer in the Faculty of Medical Sciences at the University of the West Indies, Mona campus. He received his Bachelor of Medicine and Bachelor of Surgery degree and his postgraduate Doctor of Medicine in Urology from the UWI. He also has training in urological oncology from the Mount Sinai Medical Center in Florida. Dr. Reed is a president of the Jamaica Urological Society and holds membership in the Association of Surgeons of Jamaica, as well as the American and European Urological Associations. He has a special interest in urological oncology, focusing on prostate and bladder cancers. Dr. Reed, thank you for joining us. Welcome, over to you.
Thank you very much, June, and thank you very much to the MistyBlue Cancer Foundation. Just give me a moment here. I'm just trying to bring up my slides. Okay, great. So thank you very much once again. I will be discussing the methods of prostate cancer screening, and then essentially we will take a look at how does Jamaica measure up. So this will be the general outline, and some of this has already been discussed quite nicely by Dr. Ong, so I should be able to move through it quickly with regards to introduction to screening, and especially the burdens that we Jamaicans face of prostate cancer. I'll be looking directly in terms of the methods of screening for prostate cancer, the main methods, which are going to be the prostate-specific antigen, or PSA, and the digital rectal examination. And we'll look at some of the newer adjuncts or potentially newer future directions worldwide, and see if we can apply it to the Jamaican model. And then we'll finally take a look at the Jamaican experience. So what is screening? Screening in its most basic form essentially just speaks to the detection of disease when the patient has no symptoms whatsoever and allows for treatment when disease is in a curable state. And this was essentially originally developed by two gentlemen, Wilson and Youngno, and they presented these findings at the Geneva World Health Organization meeting in 1968. And I've kind of summarized it. It's generally about 10 things, but I've combined or taken all the most relevant things in terms of the principles. And we want to look at this in terms of prostate cancer. So for each one, ask yourself, does prostate cancer qualify for this? So it should be an important condition. As was mentioned in previous presentations, it is the commonest cancer here in Jamaica, not only the commonest in terms of the highest incidence, but we also have the highest mortality. Next one is, we should understand the history of the disease from the time of development to the time that you could potentially die from it. This is known to some extent. There should be a suitable test or examination to diagnose the disease. And I think suitable tests, I think that the potential screening options are pretty suitable, but is it generally acceptable? We'll discuss that later on. The test should be acceptable and there should be an accepted treatment. And as Mr. Ambo, quite readily discussed a while ago, there are well-accepted treatments to prolong life and make you a cancer survivor, especially a prostate cancer survivor. So some of this we just discussed before. Prostate cancer, second most commonly diagnosed cancer in men. And currently, it remains the commonest male cancer in Jamaica. Many years ago, in '98, Dr. Glover from Johns Hopkins had done a presentation. He had done a study looking on prostate cancer incidence in the world, and at the time it was about 304 per 100,000. Subsequent studies, we've never really been able to reproduce these findings, and currently the incidence rate for Jamaica is about 78.1 per 100,000. It remains the commonest cause of male cancer-related deaths, and the age standardized mortality rate is about 53.9 per 100,000 per year. This is a pretty, essentially a graphical representation of some of what Dr. Ong discussed before, looking at prostate cancer. I just want you to take a look at the pictures. And as you can see, the largest portion in green is 37.5% of all cancers. This is the look for breast cancer, and female cancers, I should say, with breast being the commonest. And then it's essentially a combination. For prostate cancer, we have a slightly higher incidence of prostate cancer just from total numbers than breast cancer, 17.8 versus 13.3. What is the current timing for prostate cancer screening? So at present, there's really no Ministry of Health and Wellness guideline released regarding population-based screening in Jamaica, but it's currently in development, and we should see this in a few years to come. Worldwide, there are multiple different guidelines. The US have a different one from the European, but generally in populations where you have essentially predominantly Caucasians, they recommend what they call shared decision making or early detection of prostate cancer starting at age 55, and they generally go up to about 70. Jamaica being a very high risk population, and a big part of our risk factor is based on our race, where up to 90% of our population is Black, essentially. We recommend, and this is our local expert opinion, which is what we have to guide us at present until the later one, the ones that come from the Ministry of Health are released. And we recommend all Jamaican males screen annually. So once a year, beginning at age 40 with a PSA and a digital rectal examination. We say generally till about age of 75, but it really is until it's deemed that the patient has a greater than 10-year life expectancy, because most of the studies have suggested, and this worldwide studies suggested, once you have greater than a 10-year life expectancy, screening could potentially help in terms of prolonging that life. So the main screening methods are prostate-specific antigen and a digital rectal examination. Newer potential screening methods we will discuss are multiparametric MRI and some of the biomarkers and genetic studies that are available. So prostate-specific antigen couldn't be a simpler test. It's a serum-based measurement. So you take a little blood, maybe about 2 to 3 mils of blood, and that is tested. And the normal result lies anywhere between 0 and 4 nanograms per ml. And that is in its most basic form, without trying to adjust for age, without trying to adjust for period medications that you're on. The problem with PSA is that it's not a cancer-specific marker. The higher the PSA, there is a higher chance of detecting prostate cancer if you do a prostate biopsy. And just for some figures, PSA greater than 10 nanograms per ml probably has about a 67% chance of having prostate cancer. But when the PSA is lower, only between 4 and 10, there's only about an 18% chance. If you look on, that raw figure between 0 and 4, there really is no PSA level that eliminates the risk of having prostate cancer. A large trial done in the United States, the prostate cancer prevention trial, looked at about 18,882 men. And in that trial, every man who was enrolled eventually had a prostate biopsy done at the end of the study, because as I said, it was a prostate cancer prevention trial. And they found that up to 15% of men with a PSA that was less than 4 were diagnosed with prostate cancer. There are varying factors that can affect PSA, and it's very important when you're doing screening for prostate cancer that you ask patients things that can cause an elevation in the PSA, because you might see an elevated PSA, like what Mr. Manbo discussed, and it could be secondary to an infection or some kind of inflammation. And it's not prostate cancer. But you could also have something like trauma or recent instrumentation to be honest, even having sexual intercourse the day before you do a PSA can cause a small elevation, so ejaculation can. There are certain medications that have been shown to actually decrease your PSA. So if you're using something called a 5-alpha reductase inhibitor, commonly known drugs like finasteride, Proscar, Avodart, these things can cause a decrease in your PSA. And it's important to ask a patient if they're on these kind of medications, because you might be seeing a low PSA and it's related to the medication as opposed to an actually true low PSA. So most times, unless the patient absolutely need these drugs, the 5-alpha reductase inhibitors, I will get a PSA prior to initiating them on it. So I have a baseline value. There are also some herbal medications that have been shown to decrease your PSA. So what are the challenges with the PSA? The problem with the PSA is that it has a very poor positive predictive value of only about 30% when the PSA is just between 4 and 10 nanograms per ml. The positive predictive value suggests to you that essentially the ability of the test to truly show, or rather the probability that if you have an abnormal screening test, so between 4 and 10, you will be positive for cancer when you do the confirmatory test. So only about 3 in 10 men will actually have prostate cancer with a PSA between 4 and 10. The PSA is quite sensitive, but it's not specific based on the long list of things that I just showed you that can affect the PSA levels. Also, one of the issues worldwide is the controversial results on the benefits of screening. There were 2 large randomized controlled trials involving thousands of men, one in the United States and one in Europe. One in the United States, though it had its limitations in terms of significant biases and other issues with regards to the control and treatment group, they did not find that there was any significant benefit in overall survival in that group. The group in Europe also had its own limitations, but the European group did show some survival benefit with population-based PSA screening. But it remains one of the controversial issues. I think for Jamaica, I don't think we will suffer from that issue. Or high incidence and high mortality, we could only benefit, I believe, from screening for prostate cancer. In terms of additional issues, in terms of cost, it's not very expensive if you're trying to do it privately. It runs maybe somewhere between $2,000, $3,100, and those figures may have changed over the last 6 months. And of course, if you do it in the public system, it should be free. What is definitely known is that there is no question that in most populations, from the initiation of PSA screening, there has been a stage reduction, so a big reduction in men who present with metastatic disease. The only other issue in terms of use of PSA is that it has led to the overdetection and overtreatment of very early stage disease. Despite its limitations, PSA definitely has been shown to show some survival benefit in terms of using the PSA to screen patients. And for high-risk patients, so the high risk would be those with a family history, African or even Afro-Caribbean or even the Indian Caribbean population. I believe we should see benefit by using PSA for population-based screening. I'll move on to the next area. So this is the digital rectal examination. And this is, I think for Jamaican men, one of our big barriers to screening. Remember initially we spoke about acceptable screening tests. I think most men would undergo a blood test. The digital rectal examination, anecdotally, is something that men worry about. Someone will discuss this quite well in his talk just a while ago. And I think most men are seeing this kind of picture where they're picturing a man with, huge fingers that they're gonna make him extremely uncomfortable. But the reality is that it's a very simple test. It's mildly uncomfortable when properly performed. It's very short, usually about 15 seconds in length. And there are virtually no physical side effects. You rarely may detect prostate cancer in a patient with a normal PSA level, and this is probably one of its benefits, because it is possible to have a very hard nodular prostate in the setting of a normal PSA. And that is explained by the fact that how cancers work is that you have the original cell. That original cell changes a little bit and becomes cancerous. Now, when you have the original cell on one side and it changes extremely to a completely different cell, the normal cell would have produced a certain amount of PSA, while the very, very abnormal cell would produce very little PSA. So it is possible to have a prostate cancer that is so poorly differentiated, so different from its origin, that these cells will produce no PSA. And when you do that blood test, your PSA is going to be quite low and you'll feel very comfortable and safe. But if you put a finger in and you feel that prostate, you could feel a very abnormal cancerous prostate. And the only way you'd have detected it is by doing this digital rectal examination. This is a picture just showing what it involves on different stages of disease. So stage 1 disease, you won't feel any cancer. Stage 2, you'll just start to feel a small nodule. Stage 3, a little bit more, and it's starting to go outside of the prostate a bit. And stage 4 is where it actually has now invaded into the surrounding structures. Very simple test. You might be able to pick up something like a stage 3 or stage 4 in a very abnormal prostate. But what are some of the limitations? So here in Jamaica, I think a big one is it's not culturally acceptable. More importantly, from a screening tool, it has limited sensitivity and specificity. It has a very poor positive predictive value. And as I mentioned before, your positive predictive value is a probability that if your screening test is abnormal, you have cancer. Figures of 4 to 21% are extremely low. Poor reproducibility. So if I did this test versus someone who has done it maybe once or 1 to 10 times, it's likely that if I find something, they may not find it. It's not reproducible among all of us as physicians. It should not be used as a standalone test in the diagnosis of prostate cancer, but rather as a complementary test along with your serum PSA in an asymptomatic man being screened for prostate cancer. It should also be performed in all men with an abnormal PSA to aid in your decisions regarding a biopsy. But if you feel an abnormal rectal examination, regardless of what the PSA result is, these patients may be harboring some high-grade cancers and should undergo a prostate biopsy. The newer potential adjuncts. So we have multiparametric MRI. And this is one of the new exciting areas with regard to prostate cancer and prostate cancer diagnosis. And if you can visualize this picture, so all of this is your prostate, and this thing around the red, this dark area here, is essentially showing an area of prostate cancer. So it actually has a nice standardized scoring system where you're able to look at, it's called the PIRADS, or Prostate Imaging Reporting and Data System, and gives a score between 1 and 5. 1 and 2 suggest that whatever you're seeing in the prostate is likely not cancerous. 4 and 5, very suspicious for cancer. And in 3, where it's not quite normal, but it's not quite cancerous, and you need to take a closer look. So that advantage of MRI is that it allows visualization of the entire prostate. When we typically see a patient with an elevated PSA and we send for a biopsy, though it's ultrasound guided, we tend to biopsy just that peripheral, very, very lateral area to the sides of the prostate that tends to have about 90% of all prostate cancers. The advantage of MRI is that you can't see these lesions anywhere in the prostate and you're not able to target it. So one, you get a better pick-up rate from your biopsies. And if it is that you have a mildly elevated PSA and you do an MRI and it looks completely normal, you can potentially avoid some unnecessary biopsies. The system is not perfect. It is expensive. It is only as good as the person reading the images, and it's far more accurate when it's read by a radiologist who is an expert in that area. Even in expert centers, such as in the US and the UK, they will miss up to 15% of prostate cancers just by with MRI alone. So it's not yet perfect, but it's definitely a nice added thing in terms of our fight for detecting prostate cancer. not widely available throughout the country. I'm aware of at least 2 companies that offer this multiparametric MRI for prostate cancer that give pretty good results. It is not yet recommended worldwide as an initial screening tool, but it can be used or triggered in the event of an elevated PSA or an abnormal rectal examination, and will improve the accuracy of detecting clinically significant prostate cancer. Some other potential screening tools, and I put for the future, but some of this is being used even at present. So the top one I'd say are some of the PSA derivatives, and the one that's probably most utilized here in Jamaica is use of percent-free PSA and the free to total ratio, which I'm sure a lot of our family practitioners or a lot of people actually use. Now, its use is quite limited. So even though you get this, that percentage and the question of abnormal things for prostate cancer, its use is only really recommended for that PSA that's between 4 and 10 nanograms per ml. And it's actually not recommended as a screening tool, but rather if it is that you have an elevated PSA in the past, you have a biopsy, it does not show prostate cancer, you can use the percent-free PSA to total ratio to help you decide if the patient should either have a new biopsy or go on to have an MRI. Other things like your PSA density, which is just a measure of the PSA over the size of the prostate, can be useful as well. Because if the bigger prostate, you would expect to have a higher PSA level. And there are quite a few studies looking at this PSA density that is suggested that if you have a PSA density over 0.15, after you put your PSA over the volume of the prostate and it's greater than 0.15, there's a higher chance of having cancer in the prostate. Your PSA velocity looks on essentially that rate of rise of your PSA each year. And then there's certain other derivatives, your prostate health index and your 4K score test, not available here in Jamaica, neither is the select MDX test. Another interesting area that is being studied at present is looking at genetic markers to try and decide if these patients should go on or be screened even earlier for prostate cancer. So the top genetic issue so far detected is the presence of BRCA2. So there are other associations, BRCA1, and some other mismatch repair genes as well, and other syndromes. But this is an area not quite ready for prime time, but something in the works. And likely over the next 5 to 10 years, you may see even more. You may even see some Jamaican studies looking at genetic markers and its relation to prostate cancer. So moving on to where are we now with screening for prostate cancer in Jamaica? So as I said, no government-controlled population-based screening program or policy in Jamaica. As far as I'm aware, the Jamaica Cancer Society may have the most organized and largest prostate cancer screening service available to our Jamaican population. It's mainly located in Kingston, but there are quite a few branches around the rest of the country. It offers prostate cancer screening daily. Here in Kingston, pretty much it's manned by the members of the Jamaica Urological Society. So it's all urologists. We volunteer and screen. We try to screen maybe about 15 men per day, most days for the week and for the month. And then, of course, other things in terms of prostate cancer awareness. So this is Prostate Cancer Awareness Month here in September. And I am aware that a lot of healthcare professionals island-wide will offer prostate cancer screening. And one of the things I'm happy about is the executive profile, which includes the PSA, which tends to be a big trigger or something that's detected quite a lot in men either doing executive profiles for work or just for general checkups. The PSA is included in that. And we do find that it picks up quite a few men with abnormal PSAs. So I'm going to look at some of the research done on screening in Jamaica. And this was presented earlier by Dr. Ong in terms of the prostate cancer screening in Jamaica. It's also the largest national screening clinic. And it was a 10-year period, 1995 to 2005. Now I want you to take a look at the numbers. So imagine over a 10-year period between 1995 and 2005, we only screened about 1,107 men. It worked out to be about 180 men for the whole year. with the mean age being about 59.9 plus or minus 8.2 years. Now try to remember the recommendation for a high-risk population here in Jamaica. We recommend starting at age 40. The mean age that we're seeing in the screening trial is 59.9, so almost 20 years after the time that we wanted you to screen. It was about 59.9. These are some of the results. Most men only came for one screening visit, so it was a 10-year screening trial. So they would come for that first visit and they would never return. Of the 1,117 men, only 11% of them actually had abnormal results, and they were sent on to go and do a confirmatory test, which was a prostate biopsy. Unfortunately, only half, almost a little over half of those men went to go do the actual confirmatory test. So ultimately, at the end of it, only about 5.6% of all screened patients were found to have prostate cancer. So these figures would suggest to you that maybe we shouldn't be screening for prostate cancer, because if you're doing a screening trial over 10 years and only 5.6% of the men that you screened actually turned out to have prostate cancer, this would be suggestive that maybe prostate cancer is not a big issue, but there are significant limitations detected in the study. This is another test. So, you know, that first test, that first trial or first research paper was looking on all the, you know, the general population. So this paper was done by Dr. McNaughton, William Rickey, and Dr. McGrowder, looking at factors affecting prostate cancer screening behavior in a discrete population of doctors at the University Hospital of the West Indies. Because, you know, you're now trying to eliminate knowledge and see what attitudes and what actually change your practice. So the purpose of the study was to determine knowledge, attitudes, and practices of these Jamaican male medical consultants. And all of these men were essentially between the ages of 40 and 70. The departments involved in the survey, the medicine, surgery, obstetrics and gynecology and child health. And it managed to pool about 36 male consultants between the ages of 40 and 70. So these results were quite interesting. 97% of the men knew the high incidence of prostate cancer. 85% of them believed that men should be screened at age 40 with both a PSA and digital rectal examination. 36% of them found DRE embarrassing, and these are your healthcare professionals. And only 41% of them, 41% of them had never ever had a digital rectal examination. So the physician's knowledge of prostate cancer did not predict their personal screening behaviors. And if you can expand that to Jamaica, you know, in a whole, that gives you a little bit of an idea why we're seeing this high incidence and rather and high mortality. What are some of the barriers to screening? So this was discussed before based on the Jamaican Health and Lifestyle Survey. 79% of Jamaican men never had a digital rectal examination. There's significant anxiety related to the perceived embarrassing nature of that examination. And this has been linked to screening barriers in African American and Afro-Caribbean men in multiple studies. There's a fear, and I'm really glad Tito gave his talk right before this in terms of fear of treatment-related adverse effects of prostate cancer when diagnosed, because I believe it definitely affects or patterns of screening. Because if you detect prostate cancer, then it's on your mind. You will now likely have to go and do some kind of treatment. And it's well known that the treatment for prostate cancer can have significant effect in terms of on your erectile function. It can affect your urinary continence. And so that's a big issue as well. Other factors that have been shown to be a barrier to screening are things like your low socioeconomic status, lack of insurance, and low prostate cancer knowledge content, which has been shown to affect our screening efforts. This is a slide that I want everybody to take home with them. So this is US studies looking on 5-year survival based on your stage of disease. So there are multiple stages of prostate cancer between 1 and 4. Stage 1 and 2 generally are curable. Stage 3 can still be cured, but you need to do multimodality treatments, so surgery, radiation, multiple other things. And in stage 4 disease, where it has metastasized and spread, and that is an incurable disease. So localized and regional essentially are talking about stage 1, 2, and 3. When you look on that 5-year relative survival, it's very rare for cancer that you can see this kind of 5-year relative survival at early stage disease. It's almost 100%. So if you're diagnosed with prostate cancer in a localized or mildly regionalized state and you undergo treatment, you will be alive in 5 years, almost universally. Prostate cancer will not be the cause of your death within that 5 years. Look on a distant metastasis. So this is stage 4 disease. That drops to 30%. So once you've detected it early, you live, or that cancer won't kill you in that 5 years, but only about 30% of men who detect it when it has spread or metastasized will be alive at the end of the 5 years. You're just looking at some figures for Jamaica. The average age of diagnosis has improved over the last few years. So our average age of diagnosis back in 2002 was about 72 years old. I believe with awareness, lots of these different campaigns, that average age of diagnosis has come down. It's now about 61 years old, and that was 2011. I suspect a new study will come out, and we should hopefully start seeing that average age of diagnosis going down further. I suspect as well if and when we do get government-based health guidelines with regards to prostate cancer, we might even begin to start seeing a stage migration. So right now, currently, the majority of our patients are diagnosed in late stage disease, which is why we have such a high mortality rate from prostate cancer. Everywhere else in the world, or rather in first world populations that have a lot more population-based, not necessarily screening, but detection of prostate cancer, they have seen a stage migration in terms of they're seeing a lot more stage 1 and 2. We're still seeing a lot of stage 3 and 4. So what are some of the lessons learned? Age at diagnosis currently higher than other regions in the world. Stage presentation much higher than these regions. We are not seeing a stage migration here in Jamaica since the introduction of PSA screening worldwide. But ultimately, there still exists no perfect screening method for prostate cancer, but the best ones we have here in Jamaica and actually worldwide are still going to be the prostate-specific antigen and the rectal examination. Screening at age 40 to 75 is the best expert recommendation at present, but this will likely change, and I've seen some of the initial changes, and some of the things that are going to come is we're going to more or less risk-based or risk-categorize patients. You're probably going to see that interval changing a little bit, probably about once every 2 years or longer, starting at age 40, and adjustments the older you get. There are definitely significant barriers to screening here in Jamaica. And though awareness and knowledge is useful in terms of helping people to go and get screened from the JHLS survey, as well as that study I presented from the healthcare professionals, it may not be enough to influence change in practice. And perhaps what we need to do is approach it from a different perspective in terms of not only just giving the knowledge, but trying to influence people to seek better health characteristics or health, better health-seeking behavior is what I'm trying to say, especially for men, because women do not have this issue. There is more work to be done. Thank you very much.
Thank you, Dr. Reed. Interesting presentation there. What can I say? Well, a participant said it's interesting, troubling, and shocking. I am sure we have a lot of questions, but we are running out of time. Dr. Reed, could you just answer the questions in the chat, please? We have to move on to the next presentation. Very good stuff. So our final presenter for the evening, by no means the least is Mr. Gerald Miller, who will speak to us on taking responsibility for your health. And he's gonna have to tell me why I should take responsibility for my health. A little bit of background for Mr. Miller. Mr. Miller is the Health Promotion and Education Officer at the Westmoreland Health Services. He has an eclectic background, having a Master of Arts in Communication for Social and Behavior Change, a Diploma in Gender Studies, and a Certificate in Social Work, all from the UWI. He is also a trained teacher, receiving his Bachelor of Arts degree in secondary education from West Indies College, now NCU, Northern Caribbean University. He has a wealth of knowledge and experience in the fields of education and health, both here in Jamaica and the UK. Mr. Miller, we thank you for agreeing to present to us. We invite you to talk to us about taking responsibility for our health. Over to you.
Thank you very much for the invitation. I am trying to share my screen. Are you seeing? Are you seeing my screen?
Yes, I'm seeing your screen. Yes, sir.
So good afternoon. I should say good night. I am happy for the invitation to share in this afternoon's or tonight's webinar session on the issue of taking responsibility for your health. And the moderator made a point, why should one take responsibility for his or her health? And the question is very simple. When we take responsibility for our health, it is going to prevent the state from spending resources that could have been used to advance other areas in our economy that are in need of critical assistance, like education. So it's important for us to understand it from that angle. But we'll get into all the intricacies of that as I present this very interesting topic. But before I do that, I want you to focus on the objectives of this presentation. There are 4 of them. So there are 4 concepts that I want to explore in this presentation tonight. And I will not read, you would have seen them on the slide there. One of the questions that most experts in the field of behavioral science will ask, why is it that our people in particular tend to prefer to take meds rather than to prevent illnesses? Sometimes we wonder, is it that our brains are wired to take medications or to prevent or delay the onset of diseases? And these are some of the critical questions that we have to ask ourselves from time to time. And so the presentation this afternoon dovetails into a framework that most persons will be familiar with in the field of behavioral science. And these concepts are, the first one is health motivation. The second one is perceived risk and the perceived cost and benefits and the perceived seriousness. So these are the 4 pillars of my presentation this afternoon, or tonight, I should say. The individual's general interest in health matters, which may correlate with personality, social class, ethnic group, and religion. And why these are critical constructs. And I should have mentioned too, under this heading, the issue of the social construction of masculinity. And you would have seen in the presentations before, wherein the previous presenters would have mentioned, alluded to the fact that our population, how our male perceive health, is centered, or it dovetails into how we see ourselves as male and the concept of masculinity. That a man must be strong and a man must not be visiting the doctor too frequently, as he might be perceived to be someone who is very weak. So these are some of the issues that we have to take into consideration when we want to get persons to take responsibility for their health. So these are some of the mitigating factors, or some of the factors that are preventing, some of the changes and the behaviors that we want persons to adopt in the society. The perceived risk. This is another critical factor that one has to take into consideration. These males, are our males perceiving, themselves to be at risk for prostate cancer? So the perception of risk is something that one has to take into consideration. And one of the critical things that we must also take into consideration, that the issue of prostate cancer, as you would have seen in Dr. Reed's presentation about the doctors and knowledge, we have knowledge in our heads. The cognition is there, but that does not always transfer into our behavior. So these are some things that must be put on the table when we are talking about taking responsibility. The risk, the perceived risk. Do we see ourselves? Do our males see themselves or perceive themselves to be at risk for prostate cancer? So these are things that must be put on the table when we're having these discussions. The issue of cost, the perceived costs and the benefits. How our males perceive prostate cancer when they look at it. When I go to a urologist to have a PSA done and to have my digital rectal done, what are the benefits to accrue from carrying out all these diagnostic processes? So they are making the connection. The test early, then the issue of their lives being prolonged, and they delay testing would facilitate in terms of their premature demise. So all these are issues that would, the male would be grappling with. That cost benefit analysis is occupying his mind as he contemplates adopting a behavior that will facilitate or enhance his own optimal health. Issue of perceived seriousness. It is often said that the fear appeal tends to grip our population, in that we tend, look with, for example, with COVID-19, we tend to be using this moral suasion, and we cajoling persons, using all the different media to see how we can get persons to adopt the behaviors that will prevent, the spreading of COVID-19. But all these cajoling and, coaxing persons, to take on these new behaviors is becoming a challenge. But the fear appeal, when you start to, get persons to see the seriousness, and persons, when persons are seeing individuals dying, from something that could have been prevented, then that is when sometimes we get the kind of behavior change that is required. So the perceived seriousness, it is something that is, wrapping, my mind is wrapping around at this time as it relates to what's the best way, as a health promotion officer and as someone who has been working with MistyBlue Foundation, to see how we can get these, our males in Westmoreland, for that matter, to adopt the behavior of, screening early, so they can, they can enjoy optimum health. And these are things that we have to take into consideration. The perceived seriousness. how do they perceive this condition? How do we get our males to understand their situation? How do we elicit from them? What are the challenges that confront them? Why are they reluctant to engage their doctors? And these things, are really important in this whole process, because if they are not eliciting and asking questions pertaining to their situation, then whatever situation that dogs them or bedevils them, then they are not going to be able to overcome them. Whatever challenges they have in terms of their attitudes will not be addressed. How do we question them? How do we engage them when when we have them in our presence, especially in the clinical setting? How does a doctor engage, a male who apparently comes to his or her facility to know more about prostate cancer? This is important. So the questioning is important, how we engage them at that level. There are some checklists that we must take into consideration, which I want to emphasize. The issue of the patient's health and their beliefs, because people in their cognition, they have different things in their schemata that many times mitigate against the behaviors that we want persons to adopt. And as you know, in our Jamaican society, we tend to gravitate towards some of our herbs, and all these cultural nuances are, factors that are big barriers to the adoption of the behaviors that we want persons to adopt. How do we reinforce the positive attitudes to health? So the male comes and does his PSA every year when it is due. That's something positive. That's good news. So we praise the patient, we praise the male, we commend them. I saw last year when we had this intervention in Sav here with MistyBlue Foundation, wherein the males, although Miss Satchwell had difficulty getting some doctors to perform the digital rectal, but the men, they stood there for a while and wait until the doctors were available to carry out the procedure. And I think that was commendable. So at that time, they were praised for their effort to stay and wait until the doctors were available. And that was something that was encouraging. So we need to praise the males when we see them do things as it relates to prostate screening. If they come early and they're asking for it, and that's very good. And what we saw there last year was commendable in the sense that we see a shift in the mindset wherein the men are asking for the digital rectal. They were asking for it. It was not forced on them. It was not entrusted on them. They were the ones who were asking for it. And that was something that was very commendable. The issue of misconception, how do we debunk these misconceptions out there, the negative attitudes? And as Mr. Manboard made the point about the issue, so many misconceptions out there and persons having, attitudes that are not encouraging the screening or the uptake of more males, having the prostate PSA being done when it is due. So these are things, how do we counter these misconceptions? So we have to challenge persons who advance these misconceptions. So when we hear them, we have to debunk them and let persons know, you give persons the correct information. The issue of appropriate course of action to suit an individual. So we always have to look at what works for an individual. So what works for me might not work for someone else. So we have to tailor something, a program for the male, who we'll see from time to time, who will engage to see how we can use, the strategies to get them to adopt the behaviors that we want them to adopt in terms of screening. And so that's the end of my presentation. And thank you very much, ladies and gentlemen.
Thank you so very much, Mr. Miller. Very informative. And thank you. Let me thank all the presenters. All the presentations were really relevant, informative, and really appreciate you taking your time to join us this evening. We're running out of time, so we're gonna have time for just about a few questions, just a couple of questions for each presenter. Let me just check. For the first question, this is a question from the MistyBlue Foundation. And so I'm going to ask Dr. Reed to answer. The foundation hosts health fairs throughout the year where we target communities of low socioeconomic condition. Screening for prostate cancer using DRE and PSA along with medical presentations have been our approach. It's the best we can offer from an economic perspective. How effective do you deem this approach towards reducing the incidence and mortality of prostate cancer in Westmoreland?
Thank you, Annette. I think that's a very good question. And I do believe, every little attempt helps. The problem with the health fairs, what you'll find is that people who come to the health fairs generally have better health seeking behavior than probably what is represented in the general community. And perhaps what we need to do is get down on the most local level, get into the communities directly, speak to the area, the people who have influence in these areas, even go to the different churches and try and see if we can somehow, as Mr. Miller says, and I think his presentation is probably just as important as every little portion of everything we've discussed, including the PSA and MRI and things like that. But the bigger issue is change the mindset of our population. Excuse me, I'll stop my video. Changing the mindset of our population to essentially seek out these behaviors, realize and understand the problems that we're having with prostate cancer, and take it from there. But I think we have to continue with the different, the health fairs, the talks, go to the different churches, continue with the PSA, rectal examination. So all the things that we are doing now, but it's not going to be enough. And I think we have to really take Mr. Miller's presentation into account in terms of trying to address the fundamental issue, which is not just a knowledge issue, but changing our practice to changing, the incidence and the mortality of prostate cancer.
Thank you, Dr. Reed. Here is another question. Screening for prostate cancer starts at around age 40. How effective do you think it would be if concept of cancer awareness and preventative health is introduced within the secondary education level?
No, that is an excellent point. I think that it's not only just with regard to screening that this would be helpful. As you recall Dr. presentation talking about some of the things that will reduce your potential risk for prostate cancer. So from a dietary and lifestyle point of view, that's not a dietary and lifestyle point of view starting at age 40 or age 45, but rather, the previous 10, 15 years before. So if we're educating, our population, even from a secondary school perspective, we're trying to hit people in their second, third decade in terms of the knowledge associated with better health seeking behaviors. And it's very likely you will see, that runoff later down in terms of improvement. One in terms of screening and those who will actually develop the disease. Because if you're eating healthier, you exercise and things like that. It's not going to eliminate the risk of prostate cancer, but it's definitely going to either reduce that risk, or if you do develop prostate cancer, you will ultimately do better by having that change.
Thank you, Dr. Reed. Can we put Mr. Miller on mute? All right. I have a question actually. Myself and Dr. Perkins are actually doing this chapter on professionalism in the healthcare sector. And it's, I mean, just seeing the research about how doctors, their attitudes towards doing the DRE, it's a bit troubling. Is there anything in place, or what can be put in place to sensitize doctors in Jamaica to change the culture, to get them to be professionals, really, because this is something that needs to be done. So how do you get them to understand that they need to be doing this and recommending this to especially primary care professionals?
Okay, so that study was really just a kind of snapshot of things that were happening at the university at the time. And what's interesting is, I've spoken to some of the participants of the survey, and just by publishing these results, and they kind of saw how embarrassing it was that you had we know prostate cancer is a big issue. We know that it's a high incidence, high mortality issue, and they themselves were not participating or even recommending their patients all the time for prostate cancer screening. Just by that, it did change their perception. And it's interesting when it is that your face, when you actually have the mirror looking at yourself, you change it. It changes your outlook and your outcome. So from a Jamaican perspective, I can't say that I find the healthcare professionals not recommending screening. I do know quite a few that are not screening themselves, and it's not from a knowledge perspective. It's very different. I can't necessarily think about a direct way for them to change their general behavior. I think it just has to be continuous education, continuous knowledge of the risk or the risks involved in not doing more for themselves and their patients. And I think we're getting there. I believe once the guidelines are published and they're well known, and they're every healthcare professional, it pops up in their email, new prostate cancer guidelines or updated prostate cancer guidelines for 2022, and they take a look on it. I think these are things that will help to hammer out, just from a healthcare professional perspective, the way forward with regard to prostate cancer.
Thank you. All right, we have another question, and we probably have to just take probably two more. One of the drawbacks for many persons is the expenses associated with testing and surgery. Can we lobby the government to consider establishing an affordable health insurance scheme?
You want me to say that as well?
Well, if you want to, or I could give you a break and ask Dr. Ung to answer. Yeah?
Sure.
Dr. Ung?
Yes, go ahead, answer, please. I want to listen. I want to hear from you as well before I answer.
Okay, so with regards to the expenses associated with testing and surgery. So interestingly, one of the big things from a government perspective is that healthcare is essentially free, and the surgeries and the tests are essentially available in the public health system. So PSA definitely can be done. VRE clearly definitely free can be done. I think MRI is debatable simply because one is cost, and the machines are there, but they're limited. and they're unlikely to serve the entire population. But for those who need it, MRI is readily or relatively available in the government system. From a treatment point of view, so especially surgeries. So while we don't necessarily offer laparoscopic, that was offered to you, to Ms. Manbold, sorry. It is available relatively in I think at Cornell Regional, there was a laparoscopic, but pretty much for the rest of the country, we do open radical prostatectomies in terms of treatment. And it hasn't really been, it's not inferior to laparoscopic or robotics from an oncological perspective, but it definitely has certain advantages from a from a cover perspective. But from a, all side effects put together, open surgery will achieve the same thing. So from the question in terms of, saying the drawbacks with regards to expenses, we can eliminate that. However, there is a caveat to that. Now, one of the big issues we do have is because it's a public system and it's essentially free, and we have so many patients with prostate cancer, what we do find is the waiting lists are quite long. So you might be detected with prostate cancer, and then, depending on which facility you are in, you may get curative surgery somewhere between 4 to 6 weeks to 2 months to 3 months, depending on what's happening. I can speak to you personally now from, the effect of COVID and that this recent COVID surge. Most of our elective surgeries have been either postponed, and we're only really doing very, very emergent things. So we're going to see some issues, I suspect, within the next 6 months to a year with regards to some of these cancer cases. One, in terms of people being diagnosed because they're fearful to go to the hospital. And even those who are diagnosed, we're kind of struggling to try and treat all our patients. We're at present still doing a majority of our cancer cases because we have limited bed spaces and things like that, and limitations in terms of COVID testing. However, we're still doing majority of our cancer cases, and we'll continue to do so until or unless the hospitals become completely overrun, in which case we will no longer be doing any elective surgery whatsoever. So in terms of an affordable health insurance scheme, I don't think the government is going to necessarily push towards that, simply because healthcare in the public setting is completely free, and it does cost a lot to maintain it free at present for all other conditions. But the options are the options for treatment still exist, even in this setting, though there are limitations.
Thank you, Dr. Reed, and I totally understand and have experienced the limitation at the UHWI. All right, we have a question from
Madam Chair, I'm sorry.
Sorry. Okay. Yes, Dr. Ong, please go ahead.
Yeah, I just want to add. Thanks, Dr. Reed, for the answer. But what we are doing is based on the presentation that you'll be hearing from all of us. I just want to point a few things. One is, any disease happen to the human being, there is a cost. Even though the government will give you free of everything, but still there is a cost. Transportation, for instance, and human cost is definitely. I'm going to put my video. All right. So human cost. I mean, like if you are sick and you can go to work and all of these things, that's a huge cost that we are talking about. So any disease, like I said, including prostate cancer, we don't want to reach to that stage. The government now is focusing heavily on the primary prevention aspect of it. And you can see obviously in our radio, Mr. Miller and all of us, we are doing health education and promotion. We know some modifiable risk factors. It's just not only for prostate cancer. We have hypertension, diabetes, non-communicable diseases. Those are huge burden on Jamaican health system. So we are Jamaican government is heavily investing on it. And second point is, it is difficult for us to engage with men, and not to mention man being a doctor is going to engage with man. Sometimes I looked at it my observation is that some doctors even don't look at you when they are talking to you. There is no engagement. That's one of the biggest challenges that we have. Yes, they are we are also a part of the society, we act like a society where it comes to digital examination and so on. But when you're not engaging with your patients and your patient is not trusting you, there's a trust, there's a relationship that needs to be established. That's something that we need to, emphasize on our juniors. And as we go along, we're going to teach them that's aspect of it. And also for our men who are not coming to our health facilities, how can we do that? And we have created a way of doing this, a way of doing adolescents clinics, where we are just opening specifically for those adolescents person who need to come to our system, so that they don't have to be seen by community members and so on. So that's another aspect of it. And also we have, if I looked at it in general sense, we have NHF, National Health Fund. We have JEDF, Jamaican Drug for Elderly Program. We have NIS Gold, all of the things. And if I tell a patient that if you have all of those cards, plus if you have any Blue Cross or any other surgical card, if you have it, you're coming to the health facility is almost free, even though some of the things will cost you, but almost free. So those are the beautiful things that the government of Jamaica has provided to the population in terms of insurance scheme. Those schemes, and most of them are not utilizing it. So I would encourage you to utilize it and also focusing on modifiable risk factors, something that you have control over. When does something happen, disease late stage and all of these things happening, and the cost is not only for you individually, family as well as a country. If you work in the government sector, that sector is going to be suffered from it. So please be focusing on primary prevention. Primary prevention. Do some exercise, eat right, you can do that, and stop smoking if you do, and moderate drinking for alcohol, and try to reduce your weight. Did you see that one of the findings that we found in Westmoreland? Men ran second in the island, obese. Most men in Westmoreland are obese persons. So something that you can do about it. And when you do all of that thing, chances of you getting prostate cancer is less and less. Thank you.
Thank you so much, Dr. Ong. Okay, we have 2 questions from Leoto McDonald's. She's asking, what is the survival rate for prostate cancer? And what is the main cause of prostate cancer? From the question 2 has already been answered, but you want to respond to her, to those questions?
Dr. to discuss the rate. But in terms of, what was the second question? What is the cause of prostate cancer?
Yes.
Yeah, it's definitely, we have no answer to the cause of prostate cancer. All we can say that it definitely seems to be related to some kind of genetic link, some genes. There are quite a few of them in terms of the development of prostate cancer. But even without the genes, some people are still getting prostate cancer. So I'd say put a pin in it, and that will be answered, I believe, someday, but we have no answer for that right now.
Okay, and her other question about the survival rate.
Survival rate depends on stage of disease. Oh, perfect. This is right there for Dr. Ong. But before, just one thing to mention, Dr. Ong, in terms of the causes, we have a strong associations. I think diet, lifestyle was definitely mentioned, and then other things like being of African heritage, the age, so the older you are, the higher the chances of developing prostate cancer, and then finally, a strong family history. And then there are other little associations like smoking, obesity, diet, and lifestyle. But otherwise, no specific true cause of prostate cancer that we have detected. All right, over to you, Dr.
Okay, thank you. So I just pulled up my presentation, a slide from the presentation. So Dr. Research, survival rate is depending on the stage and grade and extent of the tumor at the time of diagnosis. So if you recall that most patients in our setting up to this point is persons are being diagnosed at the late stage. So survival rate may not be great when you are identifying the cancer at the very late stage. Otherwise, if you identify the persons in early stage, 5-year survival rate, relative survival rate is nearly 100%. 10-year is 91%, and 15-year is 76%. But it is also my experience, when you do the postmortem for some other diseases, and that's why you found that prostate cancer is the autopsy finding. We found that the man has a CA prostate, but the person is not dying from it, dying from something else. So the prevalence rate, this is the United States data, it's not Jamaican data. Age 30 to 40 year, and you can see 2 out of 10 persons have a prostate cancer. From age 60 to 70, if you get older, 6 out of 10 persons you can find prostate cancer in that. So it's not that bad, all I have to say is, even though it's not that bad, it's still prevalent and high in Jamaica. So don't lose your sight on it. Just healthy living, healthy diet, healthy eating, healthy exercise is the way to go. Thank you.
Okay, thank you so much. I see, well, it's more of a comment than a question from Dr. Garwood. The approach to examination and investigations for cancer has to be more holistic. See, even after PSA result, the diary was normal with 2 separate exams. I think that's the last, I don't know if you want to respond to that comment, but that's the last we'll be taking the last question, last comment will be taken. Dr. Ong, Dr. Reed.
I'm sorry, that's a question? I thought you said it's a comment. Yes, holistic approach, of course. Like I said, I make the comment about the fact that we need to engage with our patients. And when you see a patient with gunshot wound, for instance, when you see a patient with any other condition they come into, cough and cold, for instance, we know that based on the age of the patient, we know that diabetes, hypertension are most prevalent in this country. So we're going to ask that question. Prostate cancer is one of the highest in this country. So we're going to ask the questions and engage with the patient and approach holistic approach. That's what I'm talking about. But for holistic approach as in disease progression, I think Dr. Reed mentioned that disease progression. PSA is not necessarily saying much about it, but you have to balance PSA with digital radiography examination. Which one is? So yearly examination based on your findings. You want to call the persons to come back 6 months time or sometimes 1 year time. So you just not only reading on the paper of the PSA results, you also examining the patient's prostate physically and trying to see whether or not it is increasing or size, the hardness of the surface, and all of these things has to be considered and make a decision. So that's how we call it. I think that's what you refer to holistic approach. It's not one or another, it's both. And also, talking to the person, what kind of behavior that the person is in. The person is drinking, is smoking, sexually active, all of these things has to be considered and approach the person, treat the persons as much for the over.
Okay, thank you so much, Dr. Ong. All right, thanks. I want to thank all our presenters this evening. Dr. Ong, Dr. Reed, Mr. Miller, and Mr. Manbood. Really appreciate that you taking the time out. I especially, and you will forgive me if I single out Mr. Pete Manbood for his presentation, his honesty, bringing a reality to prostate cancer. Thank you so much for your presentation. I am sure we all learned something or many things from this session this evening. I probably have a few takeaways. One is to take responsibility for your health. Gentlemen, do your screening. Ladies, encourage, harass, drag your partners, your male relatives, everybody to do their screening. Take responsibility for your health. It's a holistic approach. You have to eat right, you have to exercise, and all of those things come together to try to prevent prostate cancer. As we heard, we don't know the causes, but at least we try to prevent some of we know some factors that may cause it, so we try to avoid those factors. So thanks once again, ladies and gentlemen. Have yourselves a good evening and stay healthy.
Thank you so much for having us.
1 second, June, before you go, for persons who want to others, we're going to upload it to the MistyBlue YouTube page, so persons can always go there to watch it again if they want to go back through it and sort of absorb some more. So as of at the end of the week, it will be on our YouTube page. Okay, thank you.
Okay. And one more thing, may I ask that you support the MistyBlue Cancer Care Foundation in cash, kind, whatever. It's a very important organization. It's in Westmoreland now, but we want it all over. We want a branch all over Jamaica. So go support it. Contact Dorothy, and she can tell you how you can give the support that's needed. Okay? Thank you so much.